A case of neurological symptoms in a diabetic patient. A 52-year-old man, Mr. Sharma, visits the diabetic clinic in Panacea Hospital, Varanasi for his routine checkup. He has had type 2 diabetes for 15 years with generally poor glycemic control. Today, he presents with an intriguing set of symptoms that capture the attending physician's attention. Initial presentation: Mr. Sharma complains of gradual onset of numbness and tingling in both feet, progressing to the hands. Occasional burning pain in his feet, especially at night. Difficulty buttoning his shirt and frequent dropping of objects. Recent episodes of dizziness upon standing. Unexplained weight loss, despite increased appetite. Physical examination: the physician observes decreased sensation to light touch and pinprick in a stocking glove distribution. Absent ankle reflexes bilaterally. Mild weakness in finger abduction and toe extension. Orthostatic hypotension with a drop in systolic blood pressure of 25 mHg upon standing. Initial differential diagnosis: 1. Diabetic polyneuropathy, DPN. 2. Chronic inflammatory demyelinating polyneuropathy, CADP. 3. Vitamin B12 deficiency. 4. Hypothyroidism. 5. Alcoholic neuropathy. Points in favor and against each diagnosis. Diabetic polyneuropathy, DPN. Formula: long-standing poorly controlled diabetes. Symmetric distal sensory symptoms. Presence of autonomic symptoms. Orthostatic hypotension. Against: relatively rapid progression of symptoms. Presence of motor symptoms. Unusual in early DPN2. Chronic inflammatory demyelinating polyneuropathy, CIDP. 4. Presence of both sensory and motor symptoms. Potential for more rapid progression. Compared to DPN against: typically presence with proximal and distal weakness. Lack of reported fluctuations in symptoms. 3. Vitamin B12 deficiency. 4. Can cause sensory and motor symptoms associated with diabetes and metformin use. Against: typically causes more prominent posterior column signs. Absence of reported cognitive symptoms or glossitis. 3. Hypothyroidism. 4. Can cause neuropathy and myopathy associated with weight gain, contrary to patient's presentation. Against: lack of other typical symptoms, e.g. cold intolerance, constipation. Neuropathy is less common in hypothyroidism compared to diabetes 5, alcoholic neuropathy. 4. Can present with sensory and motor symptoms, often associated with autonomic dysfunction. Against: no reported history of alcohol abuse, typically more painful and burning in nature. Stepwise investigations: basic blood tests, fasting, blood glucose and HbA1c, complete blood count. Renal and liver function tests, vitamin B12 and folate levels, thyroid function tests. 2. Nerve conduction studies and electromyography, NCSL EMG. 3. Autonomic function tests, heart rate variability, tilt table test. 4. Skin biopsy for intraepidermal nerve fiber density. 5. Cerebrospinal fluid analysis, because CIDP is strongly suspected. 6. Nerve biopsy, rarely needed, but may be considered if diagnosis remains unclear. Results and final diagnosis. The investigations reveal HbA1c of 9.8%, normal vitamin B12, folate and thyroid function tests. NCS EMG showing axonal polyneuropathy with some demyelinating features. Reduced intraepidermal nerve fiber density on skin biopsy. Based on these findings, Mr. Sharma is diagnosed with severe diabetic polyneuropathy with both peripheral and autonomic involvement. Treatment plan: 1. Aggressive glycemic control. Initiation of basal bolus insulin regimen. Referral to diabetes educator for glucose monitoring and insulin administration training. Management of neuropathic pain. Pregabalin titrated to effect 3. Autonomic neuropathy. Management, education on postural changes and compression stockings. Low-dose fludrocortisone for orthostatic hypotension. Regular follow-ups, monthly neurology and endocrinology checkups initially. Conclusion: this case highlights the importance of considering diabetic neuropathy as a multifaceted condition that can present with both peripheral and autonomic symptoms. It underscores the critical need for tight glycemic control in preventing and managing diabetic complications. The comprehensive approach to diagnosis and treatment demonstrates the value of a thorough clinical examination and targeted investigations in managing complex diabetic cases. Key references: the Dyke P.J., Albers, J.W., Anderson H. et al., Diabetic Polyneuropathies. Update on research definition, diagnostic criteria, and estimation of severity. Diabetes Metab Res Revent 2011 277 620628 22 Pop Busuyar Bolton A.J. Feldman E.L. et al. Diabetic Neuropathy. Opposition statement by the American Diabetes Association. Diabetes Care 2017.40 314 Tesfaye Bolton A.J. Dyke P.J. et al. Diabetic Neuropathies. Update on definitions, diagnostic criteria, estimation of severity, and treatments. Diabetes Care 2010.3 310 2285.2293